This video demonstrates the key surgical steps of laparoscopic sacrocolpopexy, promontofixation, for the treatment of urogenital prolapse. This technique provides a durable anatomical and functional restoration of pelvic organ support. The main stages include exposure of the sacral promontory, anterior and The ureter must be clearly identified and preserved throughout the dissection. Exposure of the sacral promontory is achieved by incising the peritoneum overlying the promontory, followed by identification of the anterior longitudinal ligament. Careful dissection is carried out in this area to avoid injury to the right ureter and hypogastric vessels. The peritoneum overlying the sacral promontory is then incised longitudinally to access the presacral space. Careful dissection is performed to expose the anterior longitudinal ligament, which provides the site of mesh fixation. Particular attention is paid to identifying and protecting the right ureter, the middle sacral vessels, and the hypogastric plexus in order to minimize the risk of vascular or nerve injury. Once the anterior longitudinal ligament is exposed, the mesh is anchored to it using non-absorbable sutures placed under direct vision. Sutures are passed carefully through the ligament without penetrating too deeply, in order to avoid injury to the underlying intervertebral disc or major vessels. Following the dissection and exposure of the sacral promontory, we now proceed to the laparoscopic hysterectomy. The round ligament is coagulated and transected, followed by dissection of the anterior and posterior leaves of the broad ligament.
A right ovarian cyst of benign appearance had been identified on preoperative ultrasound. Accordingly, in addition to the planned laparoscopic subtotal hysterectomy, the procedure was completed with a right adnexectomy. After identifying the vesicouterine peritoneal fold, a transverse incision is made to enter the vesicovaginal space. The bladder is gently dissected and mobilized downward from the anterior vaginal wall using a combination of sharp and blunt techniques, maintaining close contact with the vaginal plane to avoid inadvertent cystotomy. The dissection is carried caudally to the level of the bladder base, creating sufficient exposure of the anterior vaginal wall for secure mesh placement. Hemostasis is achieved with bipolar coagulation when necessary, with meticulous care to limit thermal spread in proximity to the bladder. The posterior vaginal wall is elevated with the vaginal manipulator, and the peritoneum of the pouch of Douglas is carefully incised transversely using bipolar energy. The rectovaginal space is then developed between the posterior vaginal fascia, rectovaginal septum, and the anterior wall of the rectum. Blunt dissection is used to gently mobilize the rectum posteriorly, while the plane is extended caudally for about 5 to 6 cm along the posterior vaginal wall. Sharp dissection may be performed if adhesions are present from prior surgery or inflammation. During this process, the levatorani muscles are identified bilaterally as key anatomical landmarks. Small vessels within the rectovaginal fascia are coagulated using bipolar energy, and lateral dissection is carefully limited to avoid injury to the ureters and pelvic autonomic nerves. The distal end of the polypropylene mesh is carefully positioned along the anterior vaginal wall within the vesicovaginal space, ensuring it lies flat without folds or tension. The mesh is meticulously secured to the vaginal cuff using non-absorbable sutures, taking care to protect adjacent structures such as the bladder and ureters. This step restores support to the anterior vaginal wall, reinforces the pelvic floor, and maintains proper alignment with surrounding tissues. Using monopolar energy, the uterine body is carefully transected just above the cervix, allowing for precise tissue division while minimizing thermal spread to surrounding structures. The incision is made in a controlled, circumferential manner, and the dissection is guided by clear visualization of the vesicouterine and perimetrial spaces. After completing the posterior vaginal dissection, developing the rectovaginal space, and subtotal hysterectomy, the mesh is positioned along the posterior vaginal wall and directed toward the levator ani muscles bilaterally. Using non-absorbable sutures, the mesh is carefully anchored to the medial fibers of the levator ani on each side, ensuring firm support without excessive tension. Care is taken to avoid injury to the rectum, pudendal nerves, and surrounding vascular structures,